Okay, good afternoon, everybody. My name is Sophia Lam, and I'm a data scientist at Accenture Federal Services Applied Intelligence Practice. Our COVID-19 response team has been exploring several paths of research related to the pandemic, and today I'll be focusing on the research related to social determinants of health and their relationship to COVID-19 mortality. I'll be organizing this presentation by first level setting with some definitions, providing the motivations and backgrounds for a presentation and research, analyzing the data sources, discussing caveats and assumptions, then jumping into our methods and results, and closing with our conclusion. Before we jump into our presentation, let's define some key terms that are used in our title. The World Health Organization defines social determinants of health as conditions in which people are born, grow, live, work, and age. And these are largely shaped by an individual's economic factors, power, and access to resources, and is largely responsible for various health inequities, which we've seen exacerbated throughout the pandemic. In addition, we use mortality rate, which we define as the number of confirmed deaths over the number of confirmed positive cases within a particular location. Throughout the pandemic, we've seen many research and articles posted about specific social determinants of health and how they contribute to the risk related to COVID-19 death. For example, we often see that the elderly population is disproportionately affected by COVID-19. Early in the pandemic, sites had mentioned how Italy had a higher mortality rate due to its aging population as compared to China when the pandemic first came out. In addition, we also see various sites tracking racial inequities related to the disease, where Black and Latino communities are specifically heavily impacted within the United States. In addition, due to the fact that COVID-19 attacks the respiratory system, other studies have mentioned how smoking also increases the severity, as well as other comorbidities such as obesity or diabetes. Every day we see new articles or studies talking about the influence of these factors. But can we see these effects of these factors on mortality at the county level? Our analysis today will jump into our approach to answering that question. We aggregated several resources related to socioeconomic, health, and demographic county level features to compare with COVID-19 health outcomes. Specifically, we take the age of the elderly population, the percentage of Black population, the percentage of individuals living in rural areas from the census. In addition, we also have a measure called overcrowding, which is a measure of housing density from the Department of Housing and Urban Development. We also get the percentage of smokers, on the percentage of people with diabetes and obesity from various health surveys, and the percentage of adults who are uninsured, as well as the percentage of children living in poverty. And we also calculate a variable called days since 10 to look at the number of days since a county has reported its 10th confirmed positive case. And we compare this to the mortality rate derived from the confirmed cases and deaths from the Johns Hopkins University. One thing to note about the data is that we find that case counts and deaths are dependent on the length of time that a virus has been in a location. Like I mentioned before, we calculated the days since the 10th confirmed case in a county. This figure to the right shows that the number of confirmed cases in blue and the number of deaths in red are exponentially related to time. So the longer that the virus has been in a location, the more cases and deaths have occurred. We also find that some of the variables used for our analysis are correlated with each other. One relationship to note is this relationship between virality and the time since the 10th confirmed case. This has a negative relationship showing that rural areas within the US experience their first transmissions much later than urban populations. In addition, we see that diabetes, smoking, and obesity are positively correlated with each other and have positive effects with other factors related to lower socioeconomic status, such as increased child poverty or the rate of uninsured individuals in the population. For our approach, we first started by restricting our analysis to counties with sufficient data. As of June 10, we find that 1,021 counties in the US have at least 100 confirmed cases or one death. And we do this to remove counties with inflated mortality rates due to low case counts. Next, we use the individual linear regressions to understand if any of the factors are predictors for COVID mortality. And then we perform a hypothesis test related to the regression coefficients obtained from those individual regressions. Then we also created a multivariate linear model with all the variables using forward stepwise regression for variable selection. And we also added a few variable transformations to ensure that our linear model assumptions were satisfied. Specifically, a box-Cox transformation helped us normalize the residuals on the noisy data. And finally, we use a random forest model to determine if there are any nonlinear effects or patterns that could be used as mortality predictors. Before we jump into our results, we want to discuss some caveats. For this analysis, we use linear regressions due to its explainability. However, these cannot capture all the nuances and complexities of human behavior, so we do not expect our model to have high R-squared values. In addition, since we are predicting against deaths are a small portion of the county population. Therefore, it may be difficult to tease some of the relationships due to these small percentages. As I mentioned earlier, many of the counties are at different points in the pandemic, and we use mortality rate as our estimate. As time progressed, the variation in testing capacity has increased across counties, and we can see from this recent New York Times article that testing variation is still a huge problem within our country. And our model fit is dependent on the error related to our mortality rate. So right now, we believe that mortality rates tend to be a little inflated just because we do not know the true number of COVID positive cases within a county. For our results, what we found was surprising. The data do not show a relationship between the health factors and mortality at the county level. Our hypothesis tests on the individual variables, the multivariate linear model, and random forest model have similar outcomes. For the individual hypothesis test, we found that elderly population, overcrowding, and uninsured populations, as well as day since 10, were the only statistically significant variables. In addition, in our multivariate linear model, the forward stepwise regression removes all the health factors, and the random forest variable importance plot found to the right supports the results of the model, where we can see that all of these health factors are not considered important variables. Our final model that meets assumptions uses a box-Cox transformation to normalize the residuals of the data, and we found that the only statistically significant factors were the elderly population, the uninsured population, and the days since 10 confirmed cases in a county. And our model R-squared is 0.2. In conclusion, we found that there's no observable relationship between health factors, obesity, diabetes, and smoking, and COVID-19 mortality. Only age appears to have a significant factor. This is likely a result of poor and varied testing and reporting across counties. Right now, the mortality error rate is higher than the true relationship between any of the social determinants of health and the risk of death.
Okay, 5-minute warning.
Thank you. And the error rate is concealing any of the dependencies that we would want to observe or assume that we may observe, should be able to observe. Public health officials need detailed health data at the county level. And this data can be used to understand how these factors affect the outcomes of novel diseases in real time. Our current data collection does not allow for rates of ICU admissions or ventilator use, which are precursors to mortality for this disease. And we cannot relate those to the general county health factors or socioeconomic measures that are collected in these surveys. Better data can also help us provide insights into risk factors without relating the behavior directly back to patients and jeopardizing their privacy. A more coordinated effort for testing and reporting for future novel diseases would be extremely valuable and could inform better strategy and planning at both the county and hospital level. And our research highlights that the currently available data does not allow that. This concludes my presentation, pending any questions and my acknowledgements. I'd like to acknowledge Dr. Ian McCullough for helping guide some of this presentation as well as research, and Jared and Irfan for aggregating data, and the Johns Hopkins University for aggregating all the COVID resources. And my colleagues later today will be presenting at session 3B, 4A, and 4B. So I hope that the rest of you guys can check out those works. Thank you.
All right. Well, there is one question. Well, it's not so much of a question as a statement, if you're interested in hearing it.
Yeah.
From a Mr. Chuck Coleman, stepwise regression has long been discredited because the f-tests have the wrong size. I prefer the LASSO for using random forests to find important variables to put into simpler models.
Mm-hmm. Yeah, so we used both a random forest to show variable importance, and the forward stepwise regression also produced the same results. So we kind of used both to determine which variables or predictors were important in our research.
Okay, there's one more question from Jan Galkowski. Did you make any attempt to cluster counties using a similar random forest approach? Perhaps some counties are more predictable than others because they have better health apparatus or resources.
Yeah,
Suggest doing these in a more predictable subset.
yeah, so we actually clustered counties using k-means based off of their different factors, socioeconomic factors, and we also didn't find better results with that. We basically distinguished the counties into four separate groups was the ideal cluster amount, where there's ones with like lower socioeconomic status, higher socioeconomic status, and then the other two were in the middle, more so related to COVID outcomes. So ones that started, counties that had earlier COVID transmission, etc. We also tried to parse out the counties that way too. And we aggregated this analysis to the state level to see if data was better at a more aggregated amount, but also saw some similar results where the health factors weren't seen as important.